Hello, everyone. Thank you so much for being here. My name is Allison Mayer, and I am a psychiatric mental health nurse practitioner who's had the fortunate and unique experience of working at several correctional facilities around the U.S. And today I want to talk about nurse practitioners. We are a catalyst for change in incarcerated individuals. There are so many inequities and barriers to access in healthcare faced by incarcerated individuals. The U.S. has the highest incarceration rate with over 1.7 million people. And despite the pandemic lowering those numbers, we are still over 1.7 million incarcerated people. So today I want to reach out to my healthcare professionals, to our key stakeholders in healthcare that can help make change, help advocate for this population of incarcerated individuals who are experiencing so many barriers to access in healthcare. So let's begin. I'm going to take you to my first point and address the elephant in the room, and that's who cares. That is the first thing that comes to everyone's mind, right? You might have just watched Dateline last night or watched your or listen to your podcast, your true crime podcast, and you are hearing about these murderers and these brutal killings, and you say, oh, thank God, I hope they're rotting in a jail cell right now. And it brings us to who cares. But really, we need to take a step back and think about what jail time is. And that's a time of self-reflection, of doing better, thinking about what's been done, the wrongdoings, how you got to this point, and what you can do better going forward. Okay? People that are incarcerated have limited guidance, they have scarce resources, they have barriers facing access to the legal system and legal counsel. A lot of inmates are waiting weeks, months, even years to speak to lawyers, to appeal cases, and things of that nature. So if we think of jail the way we think of a hospital, a hospital has all of these amazing resources to prevent readmission rates. I mean, most hospitals have an entire team for this. We have social workers, we have outpatient programs, follow-ups with phone calls, nurses that reach out to patients to make appointments and make sure they're following up to go to these appointments. Yeah, the patient that you just discharged with new heart failure, you don't want to see them back in 2 weeks with fluid overload. And we have all these wonderful resources to keep our patients out of hospitals. And if we applied the same thing to our correctional facilities and our jail system, we might see better results. We don't want our inmates to commit a crime and go back into society and commit the same crime, but that's what's happening. There's a cyclical system going on where inmates are being released into the same environment they came from. They aren't given the resources to do better. Their mental health is not addressed. Their physical health is not addressed. And they end up back in the same place and nothing gets done. So like I said, if we treat the jail and the judicial system like a hospital and provide these resources to these inmates to better reintegrate them into society, we will see so many better results and better outcomes for the inmates. Okay, and that brings us to our second point here. Widening disparities in incarceration rates. And so I've posted a couple statistics here, and I just wanted to go over them quick. Black U.S. residents are 5.1 times more likely than white residents to be imprisoned. American Indian or Alaskan Native U.S. residents are 4.1 times more likely than white residents to be imprisoned. Hispanic U.S. residents are 2.5 times more likely than white residents to be imprisoned. These are huge disparities in incarceration rates. And it's sad that these are people that are usually from low-income homes. They have greater mental and physical health needs. These populations tend to have higher rates of tuberculosis, HIV, hepatitis, diabetes, and psychiatric illness. More than half have a mental health problem, a substance abuse disorder, or both. And they experience these populations experience higher rates of geriatric conditions than the age-matched general population. And what does that mean? That means that inmates or people who've been incarcerated in the past are aging faster, that the system is aging them faster due to barriers to access in healthcare and their healthcare needs not being met. You say you work on an orthopedic floor and you get a patient who's 30 years old and needs a knee replacement. That would strike you as a little odd. Well, hey, why does this 30-year-old need a knee replacement? I don't usually see young patients with knee replacements. But if you think of it, like that, there are patients and inmates that are experiencing geriatric conditions, and that the age-matched general population are not. So I wanted to address a few litigation and policy points here. Some litigation that's happened in the past, and you see that these dates are pretty old. Nothing is more recent than the last 30 years, right? So we have Estelle versus Gamble, 1976. This was the failure to provide adequate health care to incarcerated people. It said the failure to provide adequate health care to incarcerated people violates the Eighth Amendment's prohibition against cruel and unusual punishment. So this was a good thing that this said we are violating the Eighth Amendment's right here with incarcerated people. And then we get to Helling versus McKinney in 1993, where inmate McKinney has filed a suit that the secondhand smoke from his roommate, from his other inmates, are posing an unreasonable risk to his health. And the court held that McKinney would be required to provide both subjective and objective elements necessary to prove Eighth Amendment violation. Okay? And then we get to a policy here. Americans with Disabilities Act, the ADA Act of 1990. And this said that jails and prisons may not discriminate against you due to a disability. So all these things have brought forth the inaccessibility in healthcare, inmates feeling ignored when their needs are not met. They feel that prison guards, brush them off if they have a concern, or they don't get to go to appointments. There's a lot of litigation as far as that goes. And so these were just some major headlining ones. And like I said, these are from a lot of these are from 30 years ago. We don't have anything terribly recent here. And that's a problem. And that brings us to the NP's position in correctional facilities. So what is the NP's position? Correctional facilities are often understaffed and unequipped to manage patients with psychiatric conditions and substance abuse disorders. They don't have the staffing, they don't have the funds, and they don't have the resources. That means that, one NP is taking care of an entire facility. A patient may wait 2 to 3 weeks for one appointment, and that doesn't really work for someone in a manic episode, right? So NPs are perfectly positioned to promote healthy behaviors and manage chronic disease. That's the whole idea behind being a nurse practitioner. We need our nurse practitioners to advocate for psychosocial needs, as well as recognize health issues that may have gone unnoticed in the past. Things like childhood traumas that have led these inmates to this point where they're doing, they're involved in crime and illegal activity. We also need to advocate in legislation for the Advanced Practice RN Modernization Act to increase the NP's scope of practice and work independently from a physician. And that's going on right now. This advocating for legislation for the APRN Modernization Act is going to help increase the scope of practice, and which increases the availability of providers for incarcerated individuals. With increasing the scope of practice, not needing a physician to spearhead orders or plans of care, that's going to open up the availability for NPs to see more patients, more NPs to get into correctional facilities without being hindered by needing a physician to make decisions. So in conclusion, I wanted to bring up a few points. I just want certification as a correctional health professional is available for physicians, mental health professionals, administrators, and RNs through the National Commission on Correctional Healthcare. There is no certification designed for NPs, yet. This is where NPs can make a huge difference, but need proper training, resources, and education to better care for patients in criminal justice health settings. That is just the point of this talk. NPs can help advocate, NPs can contribute greatly to healthcare and decreasing these barriers we have with access to healthcare in correctional facilities. And I wanted to leave you off with this quote. It says, "Nurses deliver the majority of healthcare in correctional settings and serve as the gatekeeper for inmate access to all other health services. They are the professionals most often employed to provide healthcare service for inmates, and they have more contact with patients than any other healthcare professional." And I thought that was pretty powerful because nurses have so much power and so much contact with inmates and patients in incarceration. They have the power to make change. And this quote comes from Jennifer Clifton. She's an associate professor at the University of Utah College. She's also a liaison to the National Commission on Correctional Healthcare and their board of directors. So I wanted to reiterate that NPs are the catalyst for change in correctional facilities. And with your help from healthcare providers, nurses, our CEOs, our directors, our key stakeholders in healthcare organizations, that's where we can move change forward. So thank you all so much for listening, and I hope you have a great day moving forward.